It's with great sadness that I open this session.
Hello, everyone. Delighted to welcome you to this webinar. While we are waiting for our moderator to join, I think we're experiencing some technical issues. So we will just run and start the event. In honor of our FIP president, Dominique Jordan, who passed on September 19th, August, just a few days back, would like to have a minute of silence before we start this event. Mr. Jordan was an exceptional advocate for our pharmacy profession. He was a passionate pharmacist and a really good friend to all of us. We at FIP and pharmacy globally will continue to save this federation and ensure that in trust, in solidarity and action across the globe, one FIP as a legacy will be maintained. So please just join us as we take a minute of silence on behalf of the passing of our president. Thank you. Thank you. Thank you, everyone. May his soul continue to rest in perfect and profound peace. Can we move to the next slide, please? Okay, so thank you. Today's event is about empowering early career pharmacists, having self-care interventions in common GI and respiratory symptoms for enhanced patient care. And trust me that your knowledge improved through this session.
Hi everyone again. We are having some technical difficulties with Alison, who has dropped off. So I'll just quickly pick it up from there. Our moderator today is Dr. Sham Moodley, who is a community pharmacist from South Africa. He is an EXCO member for the FIP Community Pharmacy section, and is also a vice chair for the Independent Community Pharmacy Association of South Africa. And last but not least, he's also a NEC member of the Pharmaceutical Society of South Africa. Unfortunately, he's also having some technical difficulties, and so I'll hand it over back to him when he's back online. So I'd like to extend a thank you, our sincere gratitude to the FIP team that has been coordinating this. We have had stellar leadership from Dr. Dalia Burgess, who is the FIP lead for provisions and partnerships. And also we've worked closely together with Alison and myself. So for this webinar, we'd like to just pass on a few announcements. Please note that this webinar will be recorded and is being live streamed to YouTube. The recording of the webinar will be available on the FIP website after we've completed. Please feel free to ask any questions that you have in the question box provided. And you are also welcome to provide any feedback that you have by sending an email to webinars@fip.org. Lastly, if you're not an FIP member, you can become one today by registering at www.fip.org/member registration. Thank you. And I'll hand it over now to Dr. Sham Moodley, who's back.
My sincere apologies for that. A gremlin came into the system and threw me out, and I just could not get back on. So my sincere apologies to everyone for that. So I suppose on this slide, I need to start to introduce our speakers for today. And we have a really esteemed panel today. The first that will come on will be Gonzalo Edshaw Mesega, who is a community pharmacist in the Spanish Society of Clinical, Familiar, and Community Pharmacy, Spain. Anya St. Clair Jones will then follow on, and she's a consultant pharmacist with a specialty in gastroenterology at the University Hospital Sussex NHI Foundation Trust in the UK. My colleague from the FIP CPS section, Leonela Ocampo, will follow, and she's the past president and current member of the Council of Advisors of the Philippines Pharmacy Association in the Philippines. Last but not least will be Veronica Kayugi, who's the pharmacist at Anaya Pharmaceutical in Kenya. Next slide. So none of this will ever happen if we don't have support from our funders. This event is supported by an unrestricted fund from Ricketts. Thank you very much to our sponsor, Ricketts. So the program for today, we'll start with Gonzalo, who will give us really an overview of the early career pharmacists in self-care interventions, focusing really on the education and training resources for early career pharmacists. He would be followed by Anya Wood, who will be looking at reflux and GERD. Leonela will then take us into management of irritable bowel syndrome. And lastly, we then enter the issue of the respiratory symptoms in terms of sore throat, antibiotics, etc. And Veronica will tackle that subject. We'll end with a Q&A session and hopefully wrap up in time to let you go at 2 o'clock today, South African time. Next slide, please. So each of our programs come with their own learning objectives. Today, we're going to identify reflex symptoms, risk factors, evidence-based intervention, and patient counseling techniques. We'll recognize the IBS symptoms, diagnostic challenges, and effective interventions for improved symptom control. We'll learn about evidence-based guidelines for the management of respiratory symptoms and appropriate antibiotic usage. We'll consider gender-based bias and sensitivities in patient care to foster inclusive environments when supporting individuals with self-care. Next slide. So I now hand over the floor to Gonzalo, who will introduce himself and then take over his presentation. Welcome, Gonzalo.
Thank you, Sam, and thank you everybody for being here, for joining us to this amazing event. It's my pleasure serving here at the FIP. And well, my presentation, as Sam introduced, is going to be about the added value of the early career pharmaceuticals, okay, on focusing on education and training resources for the early career pharmacist, okay? So as I said, I'm serving as community pharmacist in Spain, in the southeast, in Alicante. I'm right now serving this mandate as ECPG secretary. And well, I also take part in the Spanish Society of Clinical, Familiar and Community Pharmacy, SEFAC. So thank you and cheers from Spain, and I hope you enjoy the event, and let's get ready for learning a little about self-care. If we go through it, the next slide. These are the main learning objectives, the goals that we want to tackle, okay? So first of all is to identify the gaps that the early career pharmacist may encounter while supporting self-care interventions, especially on sore throat and gastrointestinal issues, and also to identify the challenge that the early career pharmacists encounter when playing their role in their daily activities. And last but not least, we are going to discuss the evidence based on the practices that the early career pharmacists can employ in order to solve the problems regarding sore throat and gastrointestinal issues. So if we go to the next one, we will see the outline, the main points that I want you to get to know during today's presentations. And the main important one is what is society demanding from the pharmacist, from the community pharmacist, and why I believe that self-care is the way, and the way through education and proper training, and how the early career pharmacists are right now tackling or solving these kind of issues. And well, the future, of course, no one knows how it's going to be, but I think it's going to be exciting. It's going to be full of new challenges, and we must be prepared. And that's why probably most of us, we are reunited here, okay? So please, if we go to the next one, what is society demanding from the pharmacist? Well, I'd like to say that if we are not able to adapt, others will be doing it, and then they will also be replacing us. So if we want to be serving and helping as pharmacists, we need to make sure that we are able to add value to the chain of processes, okay? All countries are growing, the world is having a huge demographic shift, and the people is aging much faster than what was happening in the past. And these are data from the World Health Organization. And we need to know that as long as the people is getting older, their health needs will be also increasing. So the pharmacist will need to be ready to help to this population that is getting older. And we need to improve the self-care of these people, to empower these kind of people in order to ensure a better health outcome. So we, the early career pharmacists, finish the degree, the pharmaceutical degree, with this perspective, and we need to get ready as soon as we start working. So if we go to the next slide, we will see that self-care recognizes the individuals and the communities as including the health promotion, the disease prevention, and really important, the self-medication. and it's also including a lot of more factors and areas. But in the end, as I said, the key element, the goal is to empower the individuals and the communities in order to gain a better health result, a better health outcome, a better well-being. So strengthen national institutions with efficient use of domestic resources for health, or the FIP members will result into a better outcome for our communities worldwide. Okay, this again is from the World Health Organization, and these are the main challenges that we are facing, and that is why having a proper education, as we are seeing in the slide, is really important, especially for early career pharmacists. I like to say always that a good pharmacist has to be like Sherlock Holmes, has to be always asking questions, because that's the only way that you are going to be ready to get to know more about your patient, about your people. So why not asking questions about self-care? That is going to give you clues, that is going to give you information about how these people, how these communities, how these individuals are managing their daily life. And with that, we have the power to solve the problem itself, and also to empower the people in order to get a better outcome. So I would like to introduce you a very little example and why I think that the self-care is the way. It is very common, at least here in Spain, that many people, especially young ladies, can be coming to the pharmacy addressing symptoms from a urinary tract infection, a UTI. And when you recognize all the symptoms, you can only at this moment send them to the medical center in order to get a proper prescription, okay, in order to get an antibiotic to treat it if needed. But there is a lot of things more that we can do through self-care in order to improve this kind of condition. We can give evidence-based natural products that can be helping prevention these things going on, and we can also give products that we can be helping the symptoms and the problems right now until the antibiotic treatment happens. Also, there are like quick tests that we could be doing in the pharmacy in order to verify if there is or there is not an infection in the urine tract. So why is the pharmacist not able to do? Probably because of the laws or the conditions of each place, but this is some evidence-based case in which we could be making advocacy in order to improve. And same kind of condition, what happens if we have another clinical case in which a person is losing weight very fast because of a very strong diarrhea? If we identify some points, we will be able to refer the person to the doctor in order to get a proper medicine, but we can recommend, we can make a pharmaceutical intervention about how to improve through self-care these kind of problems. So we need to be prepared for doing that, for being able to do that. Otherwise, we are not going to be adding value to the full process. So if we go on to the next slide, we will focus on what I think is the truly key element on why the new pharmacists are adding value to this process. On the left side, you will see the role of the pharmacist in self-care and self-medication document, which is quite old at the moment, is from the 1998. And it was one of the last documents that the World Health Organization shared, also along FIP collaboration, on how the pharmacists could be improving and helping empowering people through the self-care and the self-medication. This, through the years, has been evolving a lot into the point that the new pharmacists, as you can see in the right picture, this is a picture that was took in the university while I was a student, okay, I'm the one on the lab coat. It's a practical training, what we call a patient counseling event competition, in which we have pharmacy professors that are ensuring that we are giving a proper counseling. In the end, what we want is to make sure that we are going to have the more realistic pharmacist patient simulations, and that we are going to be getting the social and both digital competencies that the society will be demanding us. So at the moment, we need to focus on how new pharmacies can be ready for the environment that they are going to face and be transform into the more pharmaceutical care point of view, in which we focus more in the patient and the needs through self-care, for example, rather than on the medicines itself. Because in the end, the machines or the computers or the artificial intelligence will be able to do a lot of things. But it's the human factor and the connection that we have with people in a clinical point of view and human point of view, what it can add value. So I think the early career pharmacist needs to focus on this, because it's what is going to be adding value, as I said. If we go to the next slide, we will also focus on some examples that I would like to share with you about how can an early career pharmacist involve, or how can an early career pharmacist get to know more and get better in order to serve better their societies. In my case, I like to serve, as I said, in CEFAC, Spanish Clinical Society of Community and Familiar Pharmacy. And I do believe that making an effort, investing your time and your resources into be a better pharmacist, improving like how to be always learning, lifelong learning, and how to provide new pharmaceutical care services, that in the end allows you to add value to your community and in the end to the society itself. So here are a couple of pictures. One is a face-to-face interview in an optimization service that we have in the pharmacy in order to see how the medications for chronic diseases are going. And in the other two pictures, what you are seeing are two CEFAC events in which we were focusing on personalized dosage service, as you see in the right picture. And a left picture from CEFAC behind, you will see a long life learning event in which we were talking about how communication is key in order to get to know the patient needs and how to tackle through self-care, which is what we are speaking today. So just moving on to the next slide. This is one of my favorite slides. I think that if we want to preserve and if we want to keep adding value as young pharmacists, we cannot lose the human factor. And that's why there are a lot of competencies through the pharmaceutical degree that are focusing on this face-to-face and simulation with the patient, because I think and I believe that the human factor will save the pharmacy, and that is what is truly giving an output. So are we using our superpowers? I'm asking you, all of you. Just remember that we as pharmacists have a great empathy and sympathy in order to understand and to cope with the problems that the patient normally just tells you because they know you and they are confident enough with you to tell you. And because the pharmacist, especially the community pharmacist, is always available to these kind of things. So we are also drug experts, of course, so we need to be able to put these two things together, and through the non-verbal communication and the active listening in order to get a general point of view, be able to see the big picture and get the best advice through self-care, through pharmaceutical advice and indication of products, natural products always on evidence-based, we can improve a lot the health outcomes. So let's get ready for being the inner super pharmacist that is inside of all of us. And if you go to the next slides, we are just finishing this part. I want to know and share with you that the future is really exciting, that the artificial intelligence, the online activities, and the profession in the end will be changing, because it's a matter of time that everything will be changing a lot through the new technologies. So what I want to focus is that there is no better medicine than a few kind words, and that the counseling is like the key element of the self-care. We need to make a lot of questions. We need to make a connection with our patients, and we need to be ready for facing whatever it happens in the desk in the pharmacy, and also being able the new generations that we are coming to ensure that we are able to face and to use the new technologies, because this is what is going to be happening. The profession in the future will be changing, but it will keep the core values. So we need to be able to add this value to the full process. So please, if we go to the next slide, we will be finalizing with the take-home messages, which I think are truly important. And I want to share with you that our work in the pharmacy especially regarding self-care, involves a social point of view, a community point of view, and really important to empower the aspect of our patients, especially through self-care, through how they can be improving their health outcomes. Early career pharmacists also are joining the profession with a new kind of vision and training based on the person rather than the medicine itself and on the health services. So we need to go a little more further. We need to go a little more thinking on the person that is behind the problem and the medication. Of course, the future is uncertain. We must be able to develop the opportunities that arise and be able to lead the change. That is why FIP is promoting these kind of events. And last but not least, self-care and the human factor, as I said, are the tools, what I think the main tools that will favor the survival and development of the pharmacy in the world, and what will ensure that we are giving a proper and good advice always while giving self-care advice. So it was my pleasure. Please do not hesitate on making any questions or send me any email questions. I will be really happy. And thank you, FIP, for this amazing event. Thank you.
Thank you, Gonzalo. I'm going to hand over to Anya just to save some time. If you've got questions, please put them in the Q&A box. Anya, the floor is yours. Thanks, Gonzalo.
Thank you, Sham, and thank you, Gonzalo, for this amazing introduction. I'm a consultant pharmacist in gastroenterology, and I'm really passionate about developing the next generation of pharmacists. I'm involved in national groups and looking at workforce planning. Next slide, please. So I'd been asked to talk about reflux and GERD, and I just really think that you need to understand the anatomy and the pathophysiology of a disease. You need to really be very clear what are the complications and the risk factors to be confident in counselling, and you need to really be very astute in recognizing the red flag symptoms. And then, of course, we want to be able to manage the diseases and counsel the patients in a correct and safe manner. Next, please. So we're just quickly looking through definition of GERD and reflux, anatomy, risk factors, complications, a bit about the epidemiology. It's not as prevalent in every country. Red flag symptoms. I want to talk a bit about management, which is obviously the core of pharmacy practice, and side effects, ADRs and DDIs. In the next slide, we are just, what is reflux and GERD? It's dyspepsia is just any upper abdominal pain and discomfort which comes with heartburn, which is reflux, so the content of your stomach reflux. However, GERD is a chronic condition, whereas dyspepsia is anything which lasts longer than 4 weeks with these symptoms. With GERD, it's chronic, and it's usually proven with endoscopy, it's predominantly heartburn, and you can acid regurgitation. So the endoscopy will also show if you have esophagitis, which means that your esophagus is already inflamed because of being attacked continuously by acid and pepsin and bile. There are some very few conditions which are like GERD, but they're not endoscopically proven. They can't show any inflammation, but we still have to treat them. So in the next slide, we just very quickly, it's a continuous chronic reflux of the gastric content. So you have the acid, the bile, and the pepsin, which are all, of course, attacking the tissue which is not like the stomach, and therefore can cause inflammation. Why does it happen? It's usually 3 reasons. You have the transient relaxation of the lower esophagus sphincter. The lower esophagus sphincter is a sphincter which is supported by the diaphragm, which closes the stomach against the esophagus. And you can have conditions where it doesn't work very well. So either it's just transient, which is about 65% of all reflux, but you can have also a pressure on your stomach because you have a too full stomach, you're pregnant, or you do too much exercise, which then pushes the acid through the closed sphincter into the esophagus, which causes the burning sensation. Or you get spontaneous reflux without that, if your lower esophagus sphincter is permanently relaxed, so is hypotonic. We have to say that most of the reflux actually has not got many symptoms. It really depends on where in the state of the day your gut content is. So after meals, your gut content won't be too acid, so any reflux won't be so painful. Next slide, please. So the risk factors for developing GERD is obesity, some foods, smoking, pregnancy, stress particularly, and of course there is a familial history of GERD, and it's more likely. Particularly interesting is hiatus hernia, which is part of the stomach, goes through the diaphragm, and it prevents the sphincter working properly. But you also have drugs which cause GERD, and they are obviously the non-steroidals, steroids, all these. And what you have to do is you review them, you use the lowest effective dose, and if it's a prescribed drug, they need to go back to the GP or to the prescriber and say, can it be stopped? Can it be changed? And if it's over-the-counter drug, your skills should be able to really make a decision. Do they need to change? Can they continue with the medication at the lower dose? Next, please. So the complications are obviously inflammation of the esophagus. You can have hemorrhages, you can have strictures, but the really bad complication is when you have esophagitis, where the tissue changes on the lower esophagus, and it's called Barrett's syndrome. And about 10% to 15% will develop Barrett's if they have this chronic condition, and about up to 10% can then develop this into a cancer. The prevalence is particularly in North America, Europe, so it's in the developed countries, but also the Middle East, South America. So it is very prevalent. On the next slide, you see, I just thought it would be nice to just see the red countries are the ones where it's very prevalent, where you have a lot of GERD. The blue countries are interestingly not so prevalent for GERD. Next. So red flag symptoms, it's really important that you recognize which patients need to be referred and which patients need to be referred urgently. This is what we do in the UK. This is the nice red flag for GERD. So if you have appetite loss and weight loss, or you're bleeding, you need to be referred. It's not totally urgent, but you should be referred. However, if any of these symptoms or presentations are together with weight loss, so dyspepsia with weight loss, plus you're over 55 or you're a child, if you have a mass, which sounds like stomach cancer, if your reflux is with weight loss and over 55, they need to be immediately referred. In the UK, we have a 2-week rule, so a GP can refer the patient under a 2-week rule to be to access endoscopy immediately to, of course, exclude cancer. So what the next slide is showing us is how do we manage GERD? So first of all, make sure there are no red flag symptoms. I personally always think if you offer advice, make sure you have some written information and advice on the symptoms and self-care. Patients can only usually take in 3 things. So if you have a written leaflet, they have time to read it afterwards. The most important thing with managing GERD is really lifestyle change, lifestyle advice, because changing your lifestyle can improve the symptoms drastically. If that hasn't worked, you can offer some antacids. And if that then really doesn't work, you probably need to refer them or often have a trial of a PPI. Next slide, please. So in the NHS here, the UK, has a really good leaflet which you can download, and it tells the patient the do's and the don'ts. So, you know, eat small amounts, don't exercise when you're after food, try limit your weight, but it also says don't have food too late in the day, do not smoke, and all these kind of, you know, advice. So what medication in the next slide are we going to look at? The treatments, as I said, is lifestyle advice. It's the most important thing we need to do. Anybody overweight or obese needs to lose weight. It's the best thing you can do for reflux and GERD. Of course, avoid the trigger foods and eat smaller amounts more often and not late at night. Stop smoking. But what's really helpful too, particularly because your acid excretion is mainly at night, or the highest amount is at night, you raise your bed. But don't just have a cushion, raise the whole bed. If you have a cushion, you squeeze your stomach again because you're leaning slightly forward. So if they raise the bed, they have to raise the whole bed. So you're at an angle. Look for stress, anxiety management, and obviously ask them about their over-the-counter medication or any personal medication. Just review the medication. What do we use? We can use antacids, and if they have proven GERD, so they know they have a chronic disease, you give them 4 weeks of a PPI to healing, and then they can stop. So you can give them intermittent. If the person has severe esophagitis, you probably need to give PPI long-term and possibly even double the dose, depending on the symptoms. So you give 8 weeks for healing. Esophagitis takes longer to heal. And if you probably for maintenance, you need to continue with the PPIs. H. pylori tests are always worth seeing. Is it all driven by H. pylori? Next, please. Of course, we need to talk about pregnancy. GERD and reflux mainly is very prevalent in pregnancy. You've got, as I said, the pressure on your stomach by the growing fetus, and therefore the content of the stomach can pass through into the esophagus despite the sphincter normal sphincter pressure. Again, it needs lifestyle modification, antacids. Sometimes antihistamines, if the antacid fall. PPIs really should only be used in patients, in ladies who have intractable symptoms, so when we can't get on top of it. Please don't recommend nisatidine. It's not recommended in pregnancy. Don't use long-term, they should just use it intermittently as little as possible. And please don't use sodium bicarb containing medication, so the fizzy stuff, because it can give them sodium overload or fluid overload and acidosis. So, however, you know, only a minority of patients will need to step up from antacids. Most pregnant ladies will be managed with antacids. Next. So how do antacids work? Well, they basically, it's chemicals. They neutralize your acid, the chloric acid. You've got aluminium, calcium, magnesium, and bicarb containing antacids. They all probably work as well as each other, just you need to optimize it for the patient, you know, which one do they? Be aware, all of them will have side effects. So you get, particularly with babies and the over 65s, you know, be careful in certain conditions. Some cause constipations like the calcium and the aluminium. And of course, magnesium is a fantastic laxative. It will cause diarrhea, and bicarbonate will cause bloating and flatulence. Alginates, they just form a raft on top of your stomach so the acid can't go through, and they're usually used in combination with an antacid. Prokinetics, I wasn't really going to talk too much about it, but we need to talk about, because you might come across a prescription for metoclopramide for gastric emptying, to help gastric emptying, because of course, if your stomach doesn't empty well, you're more likely to have reflux due to the pressure in the stomach. And next slide, the PPIs, how do they work? They work on the H2K ATP exchange, so the hydrogen potassium ATPase. They block it, and it probably blocks about 70% of acid excretion. And they last very short-lived, so doubling the dose might be a really good way of helping. But again, this is usually reserved for really symptomatic GERD and esophagitis. You've got the antihistamines, which work on the parietal cell and prevent the histamine working, which is involved in the HK ATPase pathway. So yes, we can deal with it, but just be very aware of the side effects of these medications. So on the next slide, oh, here's the PPI dosages. These are the ones recommended in the UK. I presume everybody has very similar. So we have the full and standard dose for all the PPIs available, low dose, on the demand dose. I particularly like on demand dose because most patients need a duration of treatment and then can stop again. And then you've of course got the double dose, which we're using in Barrett's or esophagitis. Next slide. The side effects of the PPIs, I really like you to be aware of them. I won't go through them. What for me is important is that you reduce magnesium absorption, calcium absorption, iron absorption. So if somebody takes them very regularly, they probably should be managed. You obviously have problems with infections because acid, your stomach acid reduces the bugs that go through. So I'll leave that for you to look if you have time at the later stage. Next. Antacids, again, are very similar. You have problems when the patient has concomitant diseases, kidney disease, heart disease, because you affect the electrolyte balance in the stomach. So you can get constipations, you can get hypomagnesia and hypercalcemia. So we really need to be very careful who we recommend it is, and it has to be tailored to the patient. Next. So the last slide is really what I also would like you to be aware of is the drug-drug interactions with antacids. They're not just easy drugs. You're the specialist, you will be recommending. So think about drug-drug interactions where they can worsen renal and hepatic impairments through electrolyte imbalances. And also think about over-the-counter medications patient might take, which affect the effectiveness or which can counteract what we're doing. But what's really important is through the reduction, through the increase of the pH, some certain pH sensitive formulations won't be released, and sometimes it affects the stability and the solubility depending on the gastric pH, which you of course with antacids are affecting. The same with PPIs, but this is really something you need to be aware how antacids or how the change in the gastric pH can affect all sorts of formulations and stability. So at the end, what I'd like you to do is make sure you offer them lifestyle advice. It's really important. You use the shortest course of PPIs possible, and also identify the red flag symptoms, and always consider the whole patient. As Gonzalez said, you know, we think about comorbidities, the other medication, where are they in the life, what's fitting with the lifestyle. And that's hopefully given you a very quick help with managing patients with reflux. Next slide, I think references, and then over to Sham.
Thank you. That was amazing, Anya. I think there's some questions already for you in the question box, and we will feature that as we go along. I'm going to now introduce Leonella. Welcome, Leonella. The floor is yours.
Thank you very much, Sham. Good day, everyone. It's a good morning, good afternoon, and good evening, wherever you are. So thank you, my colleagues who came before me. So this is Leonella Ocampo from the Philippines. So a community pharmacist who currently is a member of the CPS Exco, the Community Pharmacy Section of FIP Exco, and member also of the Executive Board, Western Pacific Pharmaceutical Forum. So currently practicing, as I've mentioned, community pharmacist. On now to the topic that is assigned to me. So I've just identified 3 learning objectives, and this is for us to review the pathophysiology of irritable bowel syndrome and outline and understand the typical presentation of irritable bowel syndrome or IBS, then describe the recommended management for IBS and what pharmacists could do as an intervention for this condition. Okay, next slide, please. For the discussion outline, okay, let's try to revisit and understand what is IBS and its risk factors. Look at the pathophysiology, what are the clinical manifestations, signs, and symptoms. Then try to take a look at how these are being assessed and diagnosed, and what medical intervention and management is done, and what pharmacists could do to advise the patients who may come to him for this particular condition. Then to the proper next slide. As I've said, let's try to revisit what this condition is. So it's a common gastrointestinal disorder involving an abnormal condition of the gut contractions and increased gut sensations, visceral hypersensitivity characterized by abdominal pain and discomfort, gas, bloating, mucus and stools, motility, irregular bowel habits that affects the large intestines or the colon. It is also described in some references as a mix of belly discomfort and pain, and trouble with bowel habits, either going often than normal, either because one has diarrhea or constipation, or having different kind of stool, which could appear to be thin, hard, soft, and even liquid. Next slide, please. Now, it is said that IBS affects around 11% of the population globally, and this is prevalent to population within age group 15 to 50 years old, and is affecting women 2 to 2.5 times than men, and men manifest diarrhea more than women, while women manifest constipation more than men. And next, please. What are the causes for this? There are actually no exact causes being known. However, it is observed that psychological stressors is one cause when one is depressed, having anxiety, sexually abused, or have post-traumatic stress disorder. It could also be caused because of altered gastrointestinal motility, altered visceral sensation, some dietary allergies or food sensitivities. And it could also be due to neurotransmitter imbalance, where there is a decrease in the serotonin levels of the individual. And presence of luminal infection is another cause of it, where 10 to 20% of patients experience this IBS symptoms following gastroenteritis. So next slide, please. And there are 3 types for this condition known. One is constipation predominant. This is when the person tends to alternate constipation with his normal stools. Second is diarrhea predominant, where the person tends to experience diarrhea first thing in the morning or even after eating. And the third is the alternating constipation and diarrhea. It's also called IBS-A or IBS-M. Next, please. And what are the signs and symptoms? What are the clinical manifestations? So pharmacists has to take a look that these are the things that the individual would experience. It's known to us that symptoms could range from mild to severe, and this could occur at any age, but these are common in late age years. So what are these? Abdominal fullness and distension, loss of mucus from the rectum, sense of incomplete evacuation, gas and bloating, constipation, diarrhea, fatigue, and even sleep disturbance. And how are these being identified, or what are the diagnostic tests that are recommended to be done? There is actually no clear diagnostic marker that exists for IBS. Diagnosis always depends on positive clinical features and rolling out diseases by careful clinical examination and investigation. So a complete history taking, including psychosocial factors such as stress and anxiety, is needed to be taken. And of course, physical examination is done, and in some cases, barium enema is being done. Next, please. Further, ultrasound would be also recommended, stool examination, upper gastrointestinal study, and even colonoscopy and sigmoidoscopy. So these are the tests that are being conducted or being done to really determine what the condition of the patient is. Next, please. So for the diagnostic criteria, there is the use of the Rome 3 criteria for irritable bowel syndrome identification. One is the observation of a recurrent abdominal pain or discomfort that would happen at least 3 days in a month for the last 3 months. And this condition is relieved with defecation and oftentimes associated with change in frequency of stool and consistency of stool. And second, any 2 or more of the following is observed to be experienced by the individual. There is altered stool frequency, consistency, and passage of mucus, and abdominal bloating or distension. So when these are observed in the individual, then this would be indicative of irritable bowel syndrome happening in one. And for next slide, please. And there are red flag signs and symptoms. Now, I've included this because while we do encourage how we should immediately manage one who is into this condition, we also have to be aware, and we should know when we should refer the patient immediately to a medical practitioner. So these are the red flag signs and symptoms that we have to watch out for, or that we have to ask our patient if it is happening. So proper referral could be done. One is unintentional and unexplained weight loss. If this is happening, then we have to be already alert, or we have to already take this as one indication that we need to do some referral already. Rectal bleeding is happening or is experienced, and then we need to see the history of the patient or the individual, or whether there is in the family one having rectal or ovarian cancer. And then anemia is another one, abdominal mass, rectal mass, and if there are some inflammatory markers that is observed to already be indicative for IBS. Next, please. And to roll out organic causes, So these are the things that are to be done. So to really make sure that this would not come up to be a more serious medical condition, but irritable bowel syndrome, complete blood count is recommended, erythrocyte sedimentation rate, C-reactive protein. We know that this is the kind of protein that is produced by the liver, and when this happens, this is indicative of the individual to be on a medical condition that is already driving inflammation. Stool examination for ova and parasites, and of course, antibodies for celiac disease. So this is a type of autoimmune disease, and we need to really take a look at what the results of this test are in order to rule out anything that is to be interpreted more serious than irritable bowel syndrome. Next, please. And management for this, how should this be managed? Of course, we have to always bear in mind that the goal is always to relieve the symptoms. And we need to reassure the patient and do some psychological support, because this would create in the mind of the patient of something more serious happening in him. So it's important for the pharmacist who is in the front line, easily accessible by many, to be there, capable of reassuring the patients that it is just bad irritable bowel syndrome. Dietary advice is another thing that we have to do. There should not be any dairy products that the patient would be taking or the individual would be taking. Food and beverages, yogurt would be advised to be taken, but not much. And then no medications containing fructose and sorbitol, no excessive caffeine, no gas-forming food like brown beans, Brussels, cabbage, cauliflower, and onions, and high fiber diet. Next, please. And dietary advice, we can tell the individual to take probiotics, but it has to be a diet that is low in food maps, meaning the diet should be low in any fermentable oligosaccharide, disaccharide, monosaccharide, and polyols. You need to remember and be reminded that these are the short-chain carbohydrates that are poorly absorbed in the small intestines and fermented by bacteria in the colon to produce gas. Okay, next please, so it could end. And if patients is having diarrhea, she could be given loperamide or an antispasmodic to control the colon muscle spasm to reduce abdominal pain could be given. Hyoscine in-butyl bromide could be the medicine. Anticholinergic agents could be given, dicycloverine, which should be given 30 minutes before a meal to control colon muscle spasm. Now, in some instances, antidepressant is given to reduce peripheral nerve sensitivity. Next, please. Next slide. Psychotherapy is important because it's found to be effective to 2/3 of the IBS patients who do not respond to standard medical treatment. Cognitive behavioral therapy, stress management techniques, acupuncture, and hypnotherapy. So these are the management of those that are having IBS. Next, please. For patient counseling, I'm about to end. It is important for the pharmacist, may I reiterate, to reassure the patient. And this is the most successful form of treatment for IBS. Many are concerned that they are developing cancer. We have to remember that more anxiety, more colonic symptoms. Explain the functional nature of the disorder and how to avoid obvious food precipitants. Emphasize on expected chronicity of symptoms with periodic exacerbation. And we have to make clear to the client that the bowel responds to stress, food, and medications. So shy away from stress, shy away from precipitant food and medications. So I'm ending. Next slide, please. With this message, we need to understand irritable bowel syndrome well as service provider for patients and how they should be managed, as this will help us pharmacists provide the needed support that our clients need. Pharmacists can provide clients and their families the advice for the various options available in the treatment of irritable bowel syndrome. As Gonzalo had said, future is uncertain, but what is certain, which I'm sure you will agree with me, is that the pharmacists are trained to do more and be more for their clients. So we have to really work to help and support our clients with conditions that could be managed at the point where they are in our counters. So again, thank you. And we will be just coming back for some questions that you might have.
Leonella was cut off there. Thank you very much, Leonella. Let's move on then to Veronica. Welcome, Veronica. The floor is yours.
Thank you, Sham. Hello, everyone. I hope you can hear me. So welcome to my presentation. I'll be talking about empowering early career pharmacists in the self-care interventions and management of respiratory syndromes, and especially sore throat and antibiotic use. So my name is Veronica Kihugi. I am the founder and director of Pharmaceuticals. So I am passionate about health system strengthening here in Kenya and beyond, in Africa and beyond. And I hope we will be able to learn something from my presentation. Next slide, please.
Are you there, Veronica? Can't hear you.
Sorry, you can't hear me, Sham?
That's better. Got you now. Go.
Okay.
Anyone, can you hear Veronica? I can't hear at all.
Can you hear me now?
Yes, we can.
All right, sorry, I think something happened to the internet on my end. So I will cover why we need to prioritize self-care for respiratory diseases and our role as pharmacists in respiratory diseases. I'll also cover sore throat at length and how we can manage sore throat, the difference between sore throat and tonsillitis, antibiotic use in sore throat, and our role as pharmacists in patient self-care for improved respiratory health. Next slide. Respiratory diseases, as we all know, are diseases that affect any part of the airways or the lungs. So they are among the leading causes of morbidity and mortality worldwide. They affect about 81% of the population at a certain point in time within the year. And some people actually have terminal respiratory diseases that affect them throughout the year. Patients with respiratory diseases mostly seek help from community pharmacies where pharmacists are before they can go to the hospital. Next slide. So there are various respiratory diseases. They can be divided into upper and lower respiratory tract diseases. They include common cold, pharyngitis, laryngitis, tracheitis, bronchitis, influenza viruses, infections by influenza viruses, infections by adenoviruses. We also have terminal illnesses like COPD, asthma, and the recent pandemic we had COVID-19 also affecting the respiratory system. So our role as pharmacists basically in respiratory diseases is to support patients to self-care, because mostly we rush to give antibiotics, which should not be the case. We should teach patients how to care for themselves when they have these diseases. We should optimize the use of medicines. Some of these diseases require treatment using more than one drug. So we need to optimize the use of medicine so that patients do not have pill burdens and they can't adhere to their doses. We need to support people to live healthier lives. So we need to tell them what they need to do to avoid respiratory diseases. If they need to quit smoking, if they need to stay away from dust, if they need to keep warm, they need to know this so that they may not get the respiratory diseases. So we need to work more on the prevention side before we go to treatment. We also need to support people to live independently so that they know how to self-care, how to deal with their diseases before they come to the hospital or before they come to the pharmacy. Next slide. So I'll now delve into sore throat. Sore throat is basically when you have a painful, dry, or scratchy feeling in your throat. And typically it should be a self-limiting condition, and it should go away on its own without taking any antibiotics or any medications. It's commonly presented by patients, especially during winter or during the cold conditions. Causes of sore throat include viral infections, environmental factors, allergies, and smoking. Sometimes sore throat is caused by bacterial infections and mostly group A streptococcal infections, but this is less common. Mostly the sore throats that patients present with are viral infections and sometimes environmental factors. Viral causes often come with a cough, running nose, hoarseness of the throat, and sometimes it may come with conjunctivitis. Bacterial infection, that is when someone has strep throat, manifests with fever, white throat patches, so they have white patches on their throats, and inflammation. A sore throat can also stem from an allergy, a postnatal drip, dryness, excessive use of voice. So for people who work and they have to speak a lot, they may present with sore throat, reflux-related inflammation. So from GERD, and then you get a sore throat. Also, you can get sore throat if you use a lot of tobacco, if you smoke a lot, if you have weak immune systems, and if you constantly get upper respiratory infections. Next slide. So as I've said, most of the times when patients present to us, the sore throat that they have is either viral or environmental. So using antibiotics routinely is discouraged. Sore throat is a frequent upper respiratory tract infection, and if we are always giving antibiotics, then we are promoting antibiotic resistance. So we should try to do self-care first, unless we have done a lab test to confirm the presence of a bacterial infection. We should also ask the right questions when we are clerking the patient before giving any treatment or before recommending self-care. So some of the questions we need to ask is, are there noticeable red or white spots in your throat? Do you have a cough? Is the cough dry, or do you have phlegm? What is the color of the phlegm, if any? Have you experienced a fever? If so, for how long? What's the average temperature for those who may have taken their temperature, and how did you measure it? Is swallowing painful? Can you eat? Can you drink? Do you have any allergies? And do you have any other symptoms like acid reflux? So we should do proper clerking to understand the symptoms of the patient. Sometimes it could not be the sore throat that is the issue. It could be the GERD, the gastrointestinal symptoms. So we need to do the right clerking before we can offer management to the patient. Next slide. The red flag symptoms for sore throat. So a severe sore throat that has gone beyond a week may have symptoms like uncomfortable swallowing and difficulty swallowing as well. Difficulty speaking for some people if it's too chronic. It may come with breathing issues or limited mouth opening. They may also present with joint discomfort, ear pain, or neck swelling. They may have a fever that exceeds 38.3 degrees Celsius, and this may be accompanied by shivering, chills, sweating at night. Regularly, they may have sore throat instances recurring. So they have sore throat, it goes away, then it recurs after several days, and they may have persistent hoarseness that has lasted over 2 weeks. So for these patients, we should either refer to a clinician or consider doing rapid tests to test whether they have strep throat, so that we may be able to give the right treatment. Next slide. I will give the difference between sore throat and tonsillitis because these two are commonly confused, and sometimes they can be used interchangeably, but they are actually very different illnesses. Inflammation of the tonsils can occur due to strep bacteria, and also sore throat can occur due to strep bacteria. But when you get tonsils, it attacks the tonsillar glands, and the tonsillar glands, as you can see on the diagram, are found on the sides of your mouth. So the tonsillar glands act as catchers and exterminators of germs in the respiratory tract. So when a patient has tonsillitis, they have, apart from any other inflammation, they have inflammation on the tonsillar glands. Most of the times when patients have sore throat, they just have a general scratchy feeling or painful feeling in their throat. Next slide. So the steps in management. So when patients present with sore throat, we should assess the causes. We should do proper clacking, ask the right questions, ask what symptoms they have when the sore throat presented, what they have done about it. We should also assess the symptoms. If you think you need to assess the patient, you can even use a torch to check what symptoms they have, symptoms that you can see, and symptoms that the patients will talk about. So we'll be able to check also for the possibility of a strep throat based on the patient's presenting symptoms, and also whether the patient has a swollen uvula, do they have red spots in their mouth, do they have gray spots on their tongue, do they have inflamed tonsils, do they have a fever. So if it's just a sore throat that is viral, with either viral or due to environmental factors, and there's no possibility of strep throat, that is, there's no fever and there's no other symptoms as in the diagram, then these patients should be on symptomatic treatment and self-care. These patients should not be given any antibiotic because the sore throat that they have is not strep throat. It is not caused by bacteria. If there's a possibility of strep throat, that is, you have assessed the patient, they have presented with fever, the sore throat has lasted for more than a week, and they have the symptoms that are shown in the diagram, then you should refer them to a physician to do a test to actually confirm that they have strep throat before they can be given an antibiotic. For pharmacies or community pharmacists that have rapid diagnostic tests, then you can perform one on this patient to confirm whether the sore throat is actually bacterial, is due to a bacterial infection, after which now you can give an antibiotic. So the actual management, the proper management is first confirm if the patient doesn't have strep throat, refer them to symptomatic treatment, and also talk to them about self-care. If there's possibility of strep throat, we need to refer this patient for further tests. Next slide. So I'll talk about self-care remedies for sore throat. So for patients who do not have strep throat, then management is basically self-care unless we need to do symptomatic management. So lozenges or similar formulations intended to soothe the throat will work well. The patient should also take plenty of rest and take a lot of fluids and mostly warm drinks. They can use a cool mist humidifier to moisturize the air, especially if the sore throat is caused by dryness. Rest their voice until the throat feels better. If they've been speaking a lot, they should take a break from maybe work or meetings. Avoid smoking or places with a lot of smoke or other irritants. And for symptomatic treatment, we can manage any inflammation using anti-inflammatories. You can give paracetamol, you can give NSAIDs or any other analgesics. You can give sprays, lozenges that have anesthetics like benzocaine and lignocaine, and we could also give a mouthwash just to prevent any bacteria or germs that may be invading the throat area. So these are the remedies that we should talk to our patients about, the self-care remedies for sore throat management. Next slide. Antibiotics used in sore throat, as I've said, patients who have sore throat should not be given antibiotics, but unfortunately, sore throat is the most common upper respiratory tract infection where inappropriate antibiotic use occurs. So pharmacists, we are responsible to ensure that antibiotics are not given unless the case is confirmed bacterial, and we can only confirm a bacterial case by doing a diagnostic test. Viral respiratory infections, as I've said, are self-limiting and do not warrant antibiotic use. And since we should be the antibiotic stewards, we should ensure that patients are only given antibiotics when they need them. So misuse of antibiotics like azithromycin is causing a lot of antibiotic resistance, which is deadly. And so we should practice the right care. We should ensure that patients who are given azithromycin, which is most commonly given, or amoxicillin and clavulanic acid, have been tested, have confirmed that they have strep throat, then they can be given antibiotics. So when strep throat is confirmed, penicillins are given as the first line agent. Macrolides like azithromycin can also be used as second line, or in cases of penicillin allergy. Next slide. So our role in self-care for improved respiratory health, we need to teach patients on respiratory disease prevention. We need to talk to them about the public health aspects of respiratory diseases. What is it that they can do to ensure that they don't get respiratory diseases, stay in clean places, wear a mask, eat a balanced diet, have proper aeration in their homes. And we should also talk to them about vaccination for the respiratory diseases for which vaccines are available. We should teach them on self-care practices so that it's not every time that they are sick that they need to come to us. Let's teach them how to use inhalers for those who need to use inhalers correctly. And let's collaborate with patients to also understand what are their barriers to self-care. Sometimes we advise what a patient cannot afford. So let's sit down with them and understand what are their barriers to accessing help, to doing self-care when they have respiratory diseases. Let's dispel any myths. Most of these patients will come over the counter to ask for azithromycin for a sore throat. So let's teach them, let's talk to them about why your sore throat does not require an antibiotic. And let's also provide point of care tests to our pharmacies or our hospitals when we can, so that we are able to test for any bacterial infections to rule them out before giving antibiotics. So this, in this diagram, is our role as pharmacists in self-care for improved respiratory health. Next slide. So my take-home message is that as pharmacists, there remains ample potential for us to further advance self-care initiatives in order to enhance patient outcomes. The possibilities are extensive and promising. So let's be the champions to ensure that patients learn self-care and we are able to improve health for all. Thank you. Over to you, Sham.
Thank you very much, Veronica. It was amazing. If I can ask all the panelists to put on their cameras, and we will deal with a few questions that's in the Q&A. The general consensus in the chat box is that this has been an absolutely brilliant session, and there's been much knowledge gained from what I can see by all those that are participating today. So I want to go straight to Anya to take on two of the questions. Anya, the first is related to ADR with PPIs, domperidone, H2 blockers, and what would you recommend as alternative treatment? So if you can take that, and the questions on the prokinetics and in terms of safety and efficacy profiles of metoclopramide, domperidone, and cisaperidone. So if you can take those two, and then I'll move on to the next one.
So very quickly, if they are have symptoms or side effects with all the treatments, really, which is most of them you've just said, you probably have to go and look at, you could use erythromycin, which is also prokinetic and works totally differently. But I really think erythromycin has got obviously the AMS issue around it. You know, do you want to go continuous long-term on an antibiotic? And the final solution, which we haven't talked about, is surgical interventions. You can do surgical interventions like a ring for the lower, higher, upper esophagus sphincter. You can put rings, and there are ways with surgery can help very extensive GERD and Barrett's. And hiatus hernia, you have to deal with the hiatus hernia surgically. So yeah, so there it's very difficult, you know. They really need to do lifetime changes, look at the antacids, and then probably, if they can't tolerate any of the medications, go to surgery. For which one is most prokinetics? We don't use cisapride at all. It's got the QT interval prolongation. So for America and I presume the EU too, it's been taken off the market. It's been a real issue around that side effect. Metoclopramide, it passes the blood-brain barrier, so you get more side effects than domperidone. Which one is more effective? Probably metoclopramide, but I wouldn't recommend it for youngsters or elderly. The effect lasts much longer with elderly patients. So in the end, you can try a bit of domperidone to see if it works, but it's just the best thing is lifestyle changes. Does that answer the questions?
Yeah, I think that certainly answers most of what was asked in that question. And I do think that the relationship between the pharmacist in practice and the surrounding healthcare professionals is something that we mustn't miss the link with, because I think we've been attempting in FIP, for example, to try and build this program of action that includes other healthcare professionals. So don't feel afraid to seek advice, especially on treatment options other than what you used to from other healthcare professionals. Let me move on to the next question that was asked around exercise and pregnancy. And Leonela, I want to give you that question with your long experience. The question is, should we recommend continuation of exercise during pregnancy? Your view on that? You can switch your...
Can you please repeat? Did not hear the question because it was frozen.
All right, if you can hear me
now.
now.
What is the question?
The question is, in pregnancy, should we recommend exercising?
In pregnancy, no, I'm sorry, because when you were saying the question a while ago, the screen, so I was not able to hear it. So the question,
yeah, I think you probably have a really bad line because we can't hear you even coming through. I wonder if one of the other panelists want to take on that question.
Pregnant women, yes, of course.
Pregnancy and exercise.
Managed, and it has to be identified, but what type of...
Now, Leonela, we can't hear you at all. So I'm going to just take you off that question. And anyone else wants to volunteer an answer to that question? Leonela's line is really...
Maybe from the GERD point of view, it would be, I always think people need to continue exercise. Just don't overdo it. From the GERD and reflux point of view, don't do it on a full stomach. Obviously, when you are very pregnant, just think that the acid can be pushed through rigorous exercise, but people need to exercise, just gentle walking, some not stomach crunching from the GERD point of view.
Yes. Agree.
Thank you for that. Leonela, we did get some of your answers. Thank you for that.
Sorry, Sham, I was disconnected. Okay, on question of the exercise, I would say yes, but it has to be a mild, moderate exercise, not very vigorous. Because, even if you're pregnant, you really have to go into that. So it has to be something that is also recommended by your doctor, what type of exercise would be taken. But always, even if pregnant, yes, exercise. As mentioned by Anya, it has to be the kind which is mild and not much vigorous.
Thank you for that. I have a question from Juliet for Veronica. Veronica, Juliet wants to know, in terms of exposure to dust for a long period, causing nosebleeds, for example, or manifestation of blood clots within the mucus, how can this be managed from your experience?
Thank you, Juliet, for the question. I hope you can hear me, Sham.
Yeah, you clear?
Yes, I think there are many reasons that would cause someone to have nosebleed, including maybe dry air or trauma or a problem with their ear, nose, and throat. So I think proper assessment needs to be done for this patient, especially by an ear, nose, and throat specialist to assess whether there's any other reason apart from the dust. I wouldn't say the dust is a reason or is not a reason why they have nosebleeds. So I think a proper assessment is needed before treatment can be commenced.
Thank you very much. Gonzalo, you answered a question online from, it was Janet, that asked a really interesting question in terms of confidence level coming out of, as a young pharmacist, out of an undergraduate, and how do you advance that? What do you do to be as confident as Veronica has been on this call, for example, or someone like yourself? And I saw some really good answers there. Can you maybe reiterate that for the rest of the audience? Thanks.
Of course, thank you for bringing the question, because I think it's quite a good thing to think about. In order to improve, we need to go for it directly. We cannot improve something without practicing it. And it is said that once gains the expertise in one field, once it reaches 10,000 hours of a professional development. So that requires really a long journey, right? And the only secret or the only key thing is that the sooner you begin, the sooner you will arrive if you keep constant on the way. My advice is that we are, at the moment, the early career pharmacists, we are digital natives as well as pharmaceutical care natives. So we have a lot of resources at our hands. So we just need to be able to look for and to embrace the journey and be able to think in the long term. So if you are doing pharmacy degree, if you are finishing, just try to look for internships, just try to look for FIP digital events like these we are having in order to get the bigger amount of experiences and trainings that will ensure you a good and smooth abilities in order to perform your daily activities as pharmacists. So that is my best question, my best advice, to start as soon as you can and to try to see what do you enjoy the most and what is going to be giving you a clue about it. And last but not least, also to try to look for a mentor, okay? If you find someone who has already walked the pathway you want to pursue it, of course, he's going to be giving you clues and is going to speak about the mistakes and the errors that happens during this journey before, so you can gain knowledge about what they are facing. So always ready to go for new experiences, do not lose time and get ready for it. Be able to look for resources on the internet and find a mentor who is going to teach you. And later you will need to find a mentee so you can pay the debt to society. Thank you really a lot. It was a huge event and I learned a lot from the other speakers as well. So it was really nice. And thank you, Sam, for bringing the question.
Great. We have about 2 minutes to close the session. Just a closing remark from Anya. I'll go around the table, 10 seconds, closing remark before we put the slides back up.
Just very clearly, I would say get a mentor. Can I just say the FIP did a series of 4 talks on mentorship. It's absolutely brilliant. Watch them.
Gonzalez? Gonzalo, your final comments?
Can you hear me now? My conclusion is that there is no good time, there is no perfect time. So please make and create the time perfect for you and start learning today. Thank you.
Leonela.
To send the message that embrace the continuous learning, be committed to lifelong learning. So you will develop the confidence that you were asking earlier.
Veronica?
My take home would be to serve patients well, we need to involve them and to understand them. Then we can strengthen our healthcare systems.
Thank you very much, everyone. If you could move one slide back, I think, yes, just a reminder that we are in Brisbane from the 24th to the 28th for the FIP Congress. Hopefully we will see you all that are online. You've booked your tickets and you're ready to fly. Next slide. So the digital events that are coming up will be found on events.fip.org. Just in terms of wrap up, it's probably appropriate to conclude with the quote from Leonella in her presentation that said that pharmacists are trained to be more and do more for their clients. We hope that as an early career pharmacist today, we stimulated your interest in the multiple clinical conditions that you can really get involved in and help your patients and give them the ability to interact with the healthcare system with knowledge, and for yourself to understand the impact that you could have in terms of your role in your own country in the healthcare environment. These are just a few of the topics of the some 30 conditions that pharmacists treat on a daily basis in terms of pharmacist intervention. To continue to learn and enjoy these resources, become a member of FIP, and please join ECPG and join the young people that are in that team. And in terms of the last slide, I want to say thank you to all our speakers and our facilitating team. Thanks for attending today, all of you that have been online and those that might come on later. I do hope that you have enjoyed the session as much as I have. The recordings for this episode will be available on www.event.fip.org. And as I missed part of right at the beginning, and I wanted to personally acknowledge the role that Dominic Jordan played, our late president, in uniting this profession and bringing it under the one FIP banner. We will continue to live your legacy. And thank you very much, everyone. Have a pleasant day and goodbye.